It's a pleasure to be here. I want to start by making some disclosures related to the discovery of ketamine that John Crystal and I initially made. Mount Sinai and myself have a patent for treatment-resistant depression and also the potential anti-suicidal effects of ketamine. We licensed that patent to Janssen Pharmaceuticals, which led to the approval of S-ketamine in March of 2019. So Mount Sinai and myself benefit financially for the sale of S-ketamine, Spravato. In addition, we've recently been awarded a patent for the use of ketamine for post-traumatic stress disorder. So if at some point that gets licensed by any pharmaceutical company, we benefit financially there as well. So what I'm going to do today is essentially tell a story of how we made the discovery of ketamine for depression. And I think there are some lessons in that process that I'll try to convey to you during the talk. The predominant hypothesis for decades has been that that depression relates to abnormalities in the monoamine systems, such as norepinephrine and serotonin, and that the antidepressants work by increasing in some fashion the function of those monoamines. And that hypothesis goes back to the mid-1960s and was the basis of the development of many antidepressants such as Prozac and Paxil, the SSRIs, and before that, the tricyclic antidepressants. And our group at Yale was very much involved in studying that hypothesis. In fact, on this slide, it just mentions a paper that we wrote actually when I was a resident back in 1981 that talked about how antidepressants work through altering receptors of the monoamines, norepinephrine and serotonin. However, over the years, and we're talking about maybe even 2 decades of research, we ultimately felt that the monoamine hypothesis that I just mentioned needed to be altered in some way. And there were a number of studies that we conducted that made us feel that way. For example, we developed, along with others, methods of reducing serotonin and norepinephrine. Serotonin by giving a drink that lowered tryptophan, the major precursor to serotonin, and lowering norepinephrine and dopamine by giving a drug that blocks its synthesis. And through many different studies, we found, for example, that when we lowered those monoamines in healthy subjects, that didn't become depressed. And we also found when we lowered those monoamines in patients who were on antidepressants, the findings, which I'll show in a minute, did not support the role of monoamines as being central to antidepressant action. And this slide summarizes some of that work, that depletion of monoamines in recently recovered patients on antidepressants did produce a relapse. However, this is the finding that really made us start thinking that we needed to look for other systems that might be involved in depression. So there were patients, when patients were on an SSRI, fluoxetine, and we lowered serotonin, they did have a recurrent of symptoms briefly. When we gave them tryptophan back, they immediately felt better again. However, when we lowered serotonin with a tricyclic antidepressant that mainly affected norepinephrine, they didn't have a return of symptoms. When we did the opposite, when we lowered norepinephrine and dopamine in patients who were feeling better on SSRIs, no return of symptoms, but the opposite with tricyclic antidepressants that affect norepinephrine. Now, you might say, well, maybe there are norepinephrine and serotonin depressions, that there's a different pathophysiology. But much research said that was not true. And you might expect that maybe patients specifically respond to SSRIs or drugs that affect norepinephrine, but that's also not true through much research, that if you respond to one drug, you tend to respond to another. So that made us think, that monoamines are involved, but there has to be another system that is involved that mediates monoamine function. But we tried over many years to enhance monoamine function to see if we can get patients better even faster, or if you're a non-responder, that we would make you better. Multiple studies. For example, we combined a drug called yohimbine, which blocked the alpha-2 adrenergic receptor, with a tricyclic, dizipramine. When you do this, there's a very high level of enhancement of norepinephrine function. So we reasoned when you give this combination, based on the monoamine hypothesis, that patients would get better faster. Or if you're a non-responder, you would get better. Well, the answer to that was no. When we gave that combination, patients did not get better. And so this was the study that we published back in 1996, where when we gave the combination compared to just the single drug alone, patients who were treatment resistant did not get better faster. So we started thinking, well, maybe if we enhance monoamines and we don't make a non-responder a responder, maybe there's a problem with the hypothesis. Then we tested the monoamine hypothesis in another way. We gave a combination of an SSRI with a drug called Pindolol. Pindolol is a 5-HT1 antagonist. So without getting into the details, when you give an SSRI plus Pindolol, you get a very large increase in serotonin function. So we thought, well, this would be another test of the monoamine hypothesis, but in this case, looking at serotonin enhancement. Well, we found that when you gave the combination of Pindolol plus an SSRI versus placebo and an SSRI, that patients did not get better in any different way. They didn't get better faster, in other words. So that raised doubts in our mind about how important serotonin might be. And then we did another study to see if we could turn treatment-resistant patients into responsive patients by this combination. And here, too, the combination did not work any better than the single SSRI drug alone. So this is summarizing a couple of studies, but when we enhanced norepinephrine function, we didn't make patients better, and when we enhanced serotonin function, we didn't make patients better. So we, and John's going to talk about this too, we started looking for other targets for antidepressant effectiveness. And ultimately, we thought, well, maybe the glutamate system is involved. The glutamate system has major effects in modulating monoamine function, and it does this in part by blocking a specific receptor, the NMDA receptor. So we thought, well, maybe that would be another target. Maybe we can manipulate the glutamate system by blocking the NMDA receptor, and maybe that would have antidepressant effects. And also, we ultimately became aware of preclinical work by Phil Skolnick and his colleagues that also suggested that maybe the NMDA receptor was involved in antidepressant action. So how did we come to ketamine? And here's where the story gets interesting. So John, and we were partners. We did all these studies together, and it was a lot of fun. John was leading a group that was looking at the effect of ketamine as a model of psychosis. To see, and we had theories that psychosis was not just mediated by dopamine systems, and that there were specific areas in the brain that were involved in psychosis and perhaps schizophrenia. and that maybe the glutamate system was involved. And we were not the only research group that was interested in this, but we took this on as a project. And we thought that using ketamine as a model to do this work was perhaps a way to go. And we thought maybe we can recapitulate some of the signs and symptoms of schizophrenia as a model, a human model of psychosis, with a drug that would tap into the complex biology of schizophrenia, and that drug was ketamine. So ultimately, and this was a line of work, but then when we thought we had run into a roadblock around the monoamine hypothesis of depression and that maybe glutamate was involved, we decided to move forward with a study looking at ketamine as an antidepressant. And this work was initially done at the VA that we were both working together in West Haven. And the interesting thing, and this is one of the messages I want to give to those the researchers, well, how do you come up with new ideas? Do you need large groups to come up with new ideas? What kinds of environment do you need to come up with transformative ideas? Well, in our case, we were working together. And pretty much every night, we would get together, usually in my office, and we would just throw out crazy ideas in a psychologically safe environment. We weren't yelling at each other like you're crazy. We said we got to move beyond the traditional hypotheses of depression and psychosis because the field was stuck. The antidepressants that were being used were discovered in the 1950s and the 1960s. The same is true for antipsychotic treatment. So we wanted to push the envelope, and we did that pretty much every night. And we thought that, as I mentioned, that maybe NMDA receptors could be involved in depression. Now, we had a number of challenges that I'm not going to go over today, but one challenge was, well, if you're going to start a new treatment, how do you come up with the dose? What dose do you use? And so we did a number of studies, pilot studies, and ultimately came up with a dose of 0.5 milligrams per kilogram over 40 minutes. And here's where luck comes involved, because we weren't positive that was the right dose. It was kind of intermediate between doses we thought were too low and doses we thought were too high. But ultimately, it turned out that was the right dose for the treatment of depression and that it was well tolerated. So this was our first study that we did when I was at Yale, and John, who's still at Yale, we did that together. And it was in a very small pilot study of just 7 patients using the dose that we came up with, and we measured depression. And these were the findings in the paper that was published in 2000. Now, there was logic to getting to ketamine. I tried to describe that to you. It didn't just come out of the blue. But I would say we were surprised how fast the response occurred. These were depressed patients with major depression. The antidepressant response was apparent within a few hours. And as I'm sure almost all of you know, that the traditional antidepressants take weeks to months to work, and here we gave a drug that worked within a few hours. We were smart enough to know that maybe we were onto something at that point. But it was only 7 patients. We weren't positive. The effect, which is also interesting, he get that early effect, but it lasted for several days. And ketamine is a short-acting drug, and here we were showing that after 3, 4 days, and even 7 days in some patients, that response was still there. It's not an antibiotic. It didn't last forever, so we knew that you're going to have to repeat the doses for a sustained antidepressant response. But we believed it, but almost nobody else did. So when we published the paper in 2000, it kind of sat there, that there weren't other groups that were attempting to replicate the original finding. I ultimately left Yale in 2000 to go to the National Institute of Mental Health to lead the mood and anxiety research program. And I had a great group there, and I suggested to Carlos Zarate and Husseini Manji that we needed to attempt to replicate that initial finding. And that led to the second study, which was ultimately published in the Archives of General Psychiatry in 2006. It's in a second group of patients, and in this case, these were treatment-resistant depressed patients who had been depressed for many years and needed help. And what we found the same thing, though, that we found that ketamine worked very quickly, it was well tolerated, and it looked like maybe this was really true because we replicated the findings. And after that paper came out, then there was a flood of research around the world, ultimately replicating that ketamine was a rapidly acting antidepressant, and methods were developed to sustain the response. I left NIH to go to Mount Sinai, and we now have a terrific group. We've continued to study ketamine. We found that when we gave it repeatedly, that it was well tolerated in terms of side effects, and that you could maintain the antidepressant response. We also found that it looked like, and there's still work going on with this, that it seemed to have anti-suicidal effects. So, that anti-suicide effect seemed, but this still needs to be worked out, that it might be independent of the antidepressant effect. But that's still an early assertion, and that would be very important if that's found to be the case. We also worked out that it could be given intranasal and still work, and that's with Spravato, S-ketamine, which is on the market. That's how it's given. It's given intranasal twice a week for a month, and then the frequency of dosage can be reduced. So it seemed to work just as well intranasal. And we also found, and this was published in 2014, and we're close to replicating this observation, that ketamine looks like it might work in post-traumatic stress disorder independently from depressive symptoms. So this is the first paper. We're working to replicate it. Other groups are also working to replicate that finding. And as I mentioned, we have a patent for this work. So if it ultimately gets approved, we would serve to benefit financially. So what does this all mean? What does this story mean about how do you make transformative discoveries? And here's I want to raise some points that you should consider. What is the process of fundamentally moving from one hypothesis to something that's very different, that might make a difference? What types of environment facilitate discovery? What is the optimal size of such research groups? Well, there's a great paper that was published recently in Nature that actually studied what kind of groups, size of groups lead to transformative discoveries. And it turns out that smaller groups, and as I mentioned, in a psychologically safe environment, tend to make the transformative discoveries that move a field from one place to a very different place. And large groups take those findings and move them forward in a more brute force way. And that was true in the work that we did. With ketamine, the research groups that John and I had at Yale, it was a small group. It was just 4 or 5 of us. And then the groups that we had at NIMH was also not very large. And the group that I'm now involved with at Mount Sinai is not very large. So it gives you, you can move fast. You're not bound by trying to move an ocean liner from one place to another. It's a small boat when it's a small research group that is thinking great thoughts. And this is the paper that was published in Nature just really a few months ago that looked at the relationship of transformative work in relation to small versus large groups. So this is, I want to leave you with some of these thoughts. So, every once in a while, a new idea comes, a shift in thinking that challenges the status quo. These innovations, these ideas require us as a field to change and adapt. And this was true with ketamine. And it can relate to the conceptions of Kuhn, who talked about revolution in science. And it's generally not an iterative process. It's a fundamental change. It's almost like a revolution in thinking that is required to make fundamental change. And we need that in psychiatry, that a lot of our hypotheses for the major diseases that we are responsible to make discovery in have had the same hypotheses. That the dopamine hypothesis has been around for schizophrenia for 60 or 70 years. That the medicines that are used are variants of the original drugs that have been discovered for psychosis. And the same is true for many other of our psychiatric diseases. It's been too slow compared to other diseases. In cancer, there are multiple new drugs that are changing the face of cancer. For other immunological diseases and cardiac disease, fundamental changes have occurred in how we think about those diseases. That needs to occur in psychiatric diseases. So what is needed for patients with serious mental illness are major paradigm shifts, in a sense, a scientific revolution in which the underlying assumptions, and it's easy to stay with an underlying assumption. John and I can attest to that. When we moved toward ketamine, there was enormous obstacles that we faced to continue this research, but they need to be challenged using new data from molecular biology, genetics, the neural circuitry, and other scientific domains so that we meet our responsibility to our patients to come up with fundamentally new treatments. So I want to end by thanking all the people that I've worked with. Transformative science is a team sport. You don't do it alone, but it's not that big of a team. I'd like to, John and I are partners in this. It's been fantastic. We go back 30 years. His daughter's a student at Mount Sinai, a med student. So it's been fun. It was fun, to work with the group at NIMH. Hussein Manji left NIMH, and he's now scientific director for neuroscience at Janssen, and has really pushed esketamine toward approval. Want to thank my Mount Sinai team. Particularly want to thank George Henniger, who's my mentor. Mentors are really important in science. And ultimately thank the Brain and Behavior Research Foundation for getting the Colvin Prize. Thank you very much.
Thank you. Herb?
Well, first, congratulations. This is terrific work, and the discovery itself is important, and the impact on the field, I think, in terms of enthusiasm about psychiatric research is great. Let me ask you one question about your point regarding small groups. To what extent can there be a collision between the urge these days to make sure people don't work by themselves and the fact that small groups seem to do things which may be better done than big groups?
Right. So you're working by yourself, and to come up with a fundamental discovery is really hard, because you need people around you to challenge your ideas. And that happened, with us. So if I came out with an idea that was wrong, John didn't hesitate and say, I think you're really off base here, and vice versa. And if I had just stayed, in my case, researching by myself, I may have gone off in directions, that were wrong, but I became so wedded to the hypothesis, and you could end up doing research in the wrong direction for 10 years. So you need a group to challenge you. but that environment, like I keep using the term psychologically safe, we have to be comfortable with each other to challenge each other and push us together.
Yes, sir.
Do you find any difference in effectiveness with people that have treatment-resistant depression with major depression and people that have treatment-resistant depression in bipolar depression? And you said that you've had good luck with the esketamine, but are there any advantages in the treatment of esketamine with esketamine compared to regular ketamine? You have the infusion.
Right. First, in terms of bipolar depression, there have been a couple of studies there that have been positive. It is important, but not enough yet to get, say, specific approval for bipolar depression. And you want to make sure that when you give ketamine for those patients, you want to be on a mood stabilizer in combination. Whether esketamine is better or worse than ketamine, there really hasn't been a direct comparison. My own opinion is that they would be, they're about the same. Yeah.
Yes, sir. Any one of these? Yeah.
Yeah. So the
Repeat
question
that.
is whether we understand why it doesn't work in some patients, and the answer to that is we don't. So that's something we're still working on. It seems to work in about 70% of patients with treatment-resistant depression, and remember, those patients have been on multiple medicines for many years. So it is a pretty good response rate, but we're not there yet to solve every form of depression.
I've heard about ketamine being promoted for OCD as well. Has that been proven? Have there been any studies for ketamine and OCD?
Yeah, so, John may be more up to date than me, but my impression is that the results are mixed, that there have been some positive studies. There's been some negative studies where it didn't seem to work, but they're small studies. So I think there needs to be larger studies in OCD to see if it does work, and if it does, are there specific subgroups of patients with OCD that it might work. So it's worth to do more research in that area.
Yes, sir.
I heard that ketamine was originally a street drug. Is that fake news, or can you elaborate on that?
No, it's not fake news, and it's been called Special K, and it is used on the street, and that was one of the obstacles that we had in pursuing ketamine as a treatment, because there was concern about abuse, and whether it would be abused in patients who got ketamine in a controlled setting. And that concern, I think, has been allayed, that there's not really any data to indicate that patients who need ketamine for treatment to get response, that we don't see abuse as a problem.
Yeah, in the back. Yep, go ahead.
Hi, thank you for joining us. You mentioned that the response rate was 70%. Is there some sort of an assumption in the field that there's going to be one drug for everybody? Or is there recognition that just like everyone has a different color hair, we're all going to need some sort of variation to get the results that an individual with their own individual biochemistry will require to get the needed results?
Right. I don't think there's one drug for everybody. Like we mentioned, that there is treatment. There are patients who don't respond to ketamine. We also don't know how well ketamine would work in non-treatment resistant depression. I think that we need to find that out, because ketamine does work fast. And patients suffer with depression. In fact, there's literature that the pain associated with depression is more than almost any medical disease. So there's still a lot of work to define for whom ketamine will work, and for those in which it doesn't, what kind of new treatments we need to come up with. ketamine, the one positive thing, among the positive things around ketamine, it has led other scientists and pharmaceutical companies to look for drugs that might be a variant of ketamine, might have a better side effect profile, might be able to be taken orally instead of intranasally. So it has opened up, a whole different area of research that I think is very positive for the field.
Yes, ma'am.
So my understanding is that cognition is one of the last things to come back after a bout of depression, and I was wondering what we know about ketamine in regards to cognition.
Yeah. So the question is about ketamine and problems with cognition. Ketamine does work on the spectrum of symptoms associated with depression, and the effect is fast on most of those symptoms. However, because we're using ketamine in patients who've been depressed for a long time, and that depression has affected their life in many ways in terms of relationships and employment and so forth, we don't recommend that you take ketamine in the absence of therapy, whether it's therapy focused on rehabilitation or relationships or employment. It should not be given in absence of that approach.
Yes, ma'am. Now, 2 more questions, Dennis.
Okay.
Hi. You said that they were still doing studies on ketamine and PTSD. Do you know if they are looking at it specifically for the low mood aspect or like the umbrella of symptoms?
If I heard you correctly, whether it's just working on depressive symptoms versus other trauma symptoms?
If they're looking specifically at the depressive symptoms or the overall umbrella of all of them.
The work is looking at the overall picture of PTSD. And in the studies conducted so far, it works on both depression, when a PTSD patient has depression, but also on the other symptoms of depression associated with traumatic memories and hyperarousal.
Okay, one last one. How about in the back there, the gentleman?
I suffer depression and epilepsy. The epilepsy, thanks to the medicine, almost went off, but the depression still goes on. Even I tried so many medicines. But what may be this, that the depression have something to do with the epilepsy?
Epilepsy.
Oh, okay.
Oh, okay.
Sorry.
Yeah, that's an interesting question because ketamine does have some anti-seizure effects. I've talked about this with some of our neurologists. And it also helps depression. And depression and epilepsy frequently go together, if I'm getting your question right. So I have suggested to our neurologist that ketamine ought to be tested in patients with epilepsy and depression. But they should stay on their anti-epileptic meds too. So it's an interesting area that should be pursued.
Dennis, thank you.
Okay.
It's absolutely great. Really appreciate it.